Hello all. So today we are going to discuss one very important test, that is skin prick test. And skin prick test is something which we all should know when we are uh, treating our respiratory allergy patients. And also this test could be useful in background of allergic rhinitis, atopic dermatitis too. So for next 20 minutes, we'll discuss few important considerations, basic science perspective of skin prick test. Myself, Dr. Shambhu Samrat Somasdar, I am a clinical pharmacologist and also I am treating allergy patients at Therapeutic Specialty Clinic of Allergy Asthma Treatment Center. So when we are talking about skin prick test, it is very important to acknowledge some historical landmark. So 1923, Dr. Arthur Koka and Dr. Robert Cooke first time coined the term atopy. And 2 years before that, that was a landmark event happened in the field of allergy, that is passive transmission of allergy, that was first time demonstrated by Dr. Prosinich and Dr. Kushner. So what happened? Dr. Kushner was allergic to fish. So now Dr. Prosinich collected the serum from Dr. Kushner and make it serial dilution and injected them into his skin in different dilution, and then after some time he was exposed to the allergen, the fish allergen, in those part where the serum was injected, and there was a wheel-like reactions. So the hypothesis was that the allergy could be transformed if we can transmit the serum from the allergic subject to non-allergic subject. But this transmission is very much limited duration. After few times, again, the skin become non-responsive. And how much the systemic reaction was, that was not actually described that time. And we all know this type of test that has certain ethical issues, and later this specific test known as PK test or Prosinich-Kushner test was abandoned due to lack of evidences. Another two important landmarks we should remember when we are talking something about allergy. In 1906, the allergy term coined first time by Clemens von Pirquet. And in 1819, Dr. John Bostock first time published one case report on allergy. Specifically, he had mentioned how the pollen exposure is related to hay fever. So actually the subject was himself, Dr. John Bostock, and he had noticed when in a certain season, certain pollen exposure increased, he had hay fever. So this was reported, the first case report of allergy, and he had demonstrated the relationship between pollen exposure and hay fever. Now, again, the landmark event in 1967, the fifth class of immunoglobulins, IgE, was discovered by Dr. Ishizakas, and equally Dr. S.G.O. Johansson was pioneer in discovering this IgE antibody. So, what is allergy? Allergy is nothing but some altered or exaggerated reaction against harmless substances. So harmless substance means generally dust mite or some pollen or some food item is harmless to us. But in certain individual, this causes altered reaction or exaggerated reaction. So that is allergy. And when we are talking about allergy, we should have a clear understanding on three important terminologies. Number one, atopy. Number two, sensitization. Number three, allergy. So what are the differences? So first of all, atopy means this is completely the genetic test state. So I am atopic means there is something that happened in my gene. So there could be some family history. Now, what is sensitization? It is completely a immunological state. So sensitization means there is something that happened in my cellular level, the immune cellular level, and I am immunologically sensitized. Now coming to the allergy, what is that? It is a purely clinical state. So there should be manifestation. And what type of manifestation? Different types of allergic manifestations. So symptoms and signs will be there. Then we can call it as allergy. So atopy is a genetic state, sensitization is an immunological state, and allergy is a clinical state. But what is the basic defect when we are talking about allergy? That we also need to know. It is the defect in epithelial integrity. So what happened as there is epithelial integrity lost, so the allergen will enters into our system, and by that they make us sensitized, and after sensitization, if we develop symptoms, then we will become allergic. So one of the major reason behind this loss of epithelial integrity is genetic. But apart from genetics, there are something known as environmental factor and also the epigenetic factors. So epigenetic factors are equally responsible for this defect in epithelial integrity. So in this picture, we can clearly see how the genetics, the environment, and also the epigenetics are responsible to develop allergy. So this could be a MCQ like that. There are certain similarity between these pictures. So we can clearly see the first picture. There is the normal air pathway become smaller. There is a airway spasm. The middle layer becomes swollen and also some mucus plugs. So this is a characteristic of our airway when we are suffering from asthma. Next picture, there is cobblestone appearance in the palpebral conjunctiva. Third picture, the boy, there is allergic shinners, the salute sign of allergic rhinitis, and we can see the beautiful picture of boggy pale inferior turbinate, which is swollen. This is also a classical picture of allergic rhinitis. And the fourth picture, what we can see, there is angioedema and urticaria. So as a whole, what we can say, this picture actually signify type 1 hypersensitivity reactions. So when we are talking about type 1 hypersensitivity reaction, it is very important to understand the mechanism of type 1 hypersensitivity reaction. The first step, as already we had mentioned, the basic defect is epithelial integrity loss. So the allergen will enters into the cell, into the system, and then what happen? There will be antigen presenting cells like dendritic cells. So they will catch the allergen or antigen here. They will represent those allergen to the naive T helper cells. So how they will represent that? So for that they need MHC, and generally in this type of cases the MHC class 2 is responsible, and MHC class 2 and T cell receptor, they have some interaction, they will take the antigen or allergen. So there will be, we know, three type of signal. First, representation, that means signal 1. Second is there will be some co-stimulatory ligands like specific CD40 or like that. So there will be a co-stimulatory ligand system activation, and after that there will be certain cytokine release from the T cells and also the antigen presenting cell, which causes the naive T helper cell to differentiate. And here, by the virtue of interleukin 4 and the atmosphere of allergen and MHC class 2 representation to T cell, they differentiate to Th2 cells. Now, the Th2 cell will produce certain cytokines. So signal 3 is happening here. So what type of cytokines? Majorly IL-4 and IL-5, also interleukin 13. They will, this Th2 cell will again represent the antigen or allergen to B cell. Now what happened? The B cell normally they will produce IgG, but here in the milieu of Th2 environment, there will be class switching. So from plasma cell, there will be lots of Ig antibodies formation. So instead of producing IgG, they will produce Ig antibodies. So there will be this type of class switching. And also the interleukin 5 plays a role on eosinophil. So eosinophil will be activated. Now what happened? Those Ig will find out the mast cell and the basophil and sit on the top of specific receptor on the mast cell. And we all know the receptor name, the Fc epsilon receptor type 2. They will sit on them, the IgE. Now, this state, when the mast cell and the Fc on top of mast cell, the Fc epsilon receptor, the IgE is sitting, we call it as sensitized cell. So this is the phase where we are talking about sensitization. So sensitization, what we had discussed, from atopy to sensitization. So this is the place where we can call, this is an immunological state, the sensitized state. Now from this sensitized state, whether there will be allergy or not, that entirely depends on how they behave with re-exposure of allergen. So now when there is re-exposure of allergen, those IgE antibody sitting on top of Fc epsilon receptor, they will catch the allergen. And this catching of the allergen cause some reaction inside the cell, and the cell become degranulate. So there will be degranulation. and there will be release of mediators, including histamine and others from the basophil and mast cell. And ultimately, the type 1 hypersensitivity reaction will set in. So by this picture, we are representing the type 1 hypersensitivity reaction. The important issue here to understand, by doing the skin prick test, actually we are evaluating the sensitization status inside us. So when we are reintroducing that particular allergen inside the when they enters under the skin, they will find out the mast cell which is already sensitized, and they will be taken by the mast cell, and the mast cell which is occupied by two Ig antibody on their Fc epsilon receptor, and ultimately that mast cell will degranulate, produce histamine, and there will be certain quill-like reaction. So by skin prick test, we are evaluating if a patient is sensitized or not sensitized. So by skin prick test, we are not measuring the free Ig value, free Ig level. We are assessing here the mast cell bound Ig qualitative, in a qualitative fashion. So this is very important to understand, because when we are interpreting skin prick test, this concept should be clear, that by skin prick test, we are assessing the sensitization status of a patient. That means this is an immunological state we are assessing. So skin prick test does not tell us about the clinical allergic state. Skin prick test tell us about the sensitization state. So few important concepts we all should understand. First of all, we can be atopic but not allergic. Why? Because atopy mean, already we had said, this, we have some genetically weird condition. So there is something happen in my gene, but we may not have the clinical manifestation. So we can be atopic but not allergic. So there are data that suggest 60 to 70% of our allergic patient, they have history of two parents suffering from allergy, whereas if the one parent is having allergic history, then it is 40 to 50% chance of their next generation to develop allergy. And if both the parent does not have any history of allergy, then also there is 20% chance of developing allergy as in their children. As we had already mentioned, apart from genetic defect, there are certain environmental and epigenetic factors which could be responsible for developing allergy. Next important concept, you can be sensitized but not allergic. So that means in your mast cell, they may carry that IgE on top of their Fc epsilon receptor, but you don't have the symptoms of allergy. So you were sensitized but not allergy. Exposure to allergen, specific allergen, that may produce specific IgE, but clinically there is no manifestation, no symptoms of allergy, no signs of allergy. So this could be possible. But it is very important to note, if I am sensitized but not allergic, I have a 10 times more chance of developing allergy in future. So we should be cautious. Third important concept: you can be allergic but not atopic. So no family history, but you can be allergic. There are chances, specifically when we are talking about some drug allergy, some insect allergy, this could be possible. If you are allergic, you are always sensitized. So I am allergic mean there is something that happened in my immunological state. So I am sensitized. And that is why when we are evaluating our allergic patient, the skin prick test is the gold standard. Because by skin prick test, we can understand to which allergen I am sensitized. So if I am allergic, I am definitely sensitized. So these four concepts we all should remember, so understand. So skin prick test, it is an in vivo assay of specific Ig to different antigens. And this specific Ig, when we are doing skin prick test, that means they are bound to mast cell. So we are assaying the mast cell bound specific Ig. Whereas in case of ELISA test, blood from the serum or total Ig total, we are assaying the free Ig level. We are not assessing the specific Ig which is bound to the muscle. So this is an immunological state. This test detect sensitization. So what happened? How this test? What is the principle of this test? First of all, there is an exposure to specific antigen in the patient system. The patient system will tell us whether I am sensitized or not. If I am sensitized, then there is some specific Ig which is bound to the muscle surface. And again, the exposure of that particular specific antigen into our skin that will be caught by those Ig. There will be a coupling reaction that with that Ig molecules which is sit on the Fc epsilon receptor of on muscle. Ultimately, there will be the reactions due to the release of mediators from the muscle like histamine, and ultimately the skin prick test help us to diagnose, to confirm, to prognosticate, and to help us in research also in the field of allergy. So when we are evaluating a cardiological patient, a heart disease patient, we need to know ECG. ECG has importance. Similarly, a pulmonologist, they are the domain expert in the field of pulmonary function test. So when we are evaluating a respiratory disease patient, we need to know pulmonary function test. Similarly, when we are evaluating a allergic disease patient, specifically the airway allergy patient and some degree of atopic dermatitis patient, the SPT is the same important, has the same importance like ECG. What ECG matters to a cardiologist, what PFT matters to a pulmonologist. So similarly, SPT is a very important and essential test for the allergist. But it is very important to note, SPT will tell us about the sensitization status. This does not diagnose the clinical allergy. So diagnosis of clinical allergy is entirely depends on the second history taking. So there will be there is one first history taking, his primary history taking. According to that, we have to do the skin prick test. And when we are analyzing the result of skin prick test, again we need to go back to the patient to ask some questions, whether the sensitized allergen has some degree of correlation with clinical history. We need to see, we need to check, and then we can finally take the decision on treatment. So when we are writing the skin prick test report, it is very important to note that we should write the patient maybe some dust mite or cockroach antigen. They are sensitized. This patient is sensitized to dust mite, cockroach allergen, cocos pollen, etc. like that. We should not write they are allergic to house dust mite, allergic to cocos, allergic to cockroach. We should not write that. We should write sensitized to house dust mite, sensitized to cocos pollen, sensitized to cockroach antigen with a good positive and negative control. So when we are actually evaluating the skin prick test, it is also important to check the normal response of the skin with histamine and with distilled water, or the negative control. So positive control here is histamine, and there should be a negative control too. So in negative control, the response should not be 3 millimeter or more diameter. And in case of positive control, the positive control should have a response of more than 3 millimeter. So this is very important. Now coming to the basic mechanism of skin prick test. First of all, the allergen enters the body. Now what happened? The antigen presenting cell, they takes up the allergen molecule and presents it epitope through MHC class 2 receptor onto its surface. The activated antigen presenting cell then migrates to nearest lymph nodes. And in lymph node, what is waiting? The T cell is waiting. The naive T cell is waiting. So this antigen presenting cell, it activates T cells. Which T cell? Now that T cell who can recognize the allergen. They then give the decision for the T cell to differentiate into Th2 cell. And then at the same time, the B cells recognize the allergen, and through the activated Th2 cell, they become also activated. They differentiate into plasma cells, from B cells to plasma cells, and at which point they would actively synthesize antibodies of the Ig isotype. So instead of producing IgG, they will produce IgE. So there will be a class switching. Now, this Ig antibody recognize the epitopes of the allergen molecules, circulates around the body through different lymphatic and vascular system. Finally, they will bind to the Fc epsilon receptor 1 on the muscle and the basophils. So this is the state. This is the immunological state, what we mention as sensitization. Now, if the allergen re-enters the body at a later time, it binds to the Ig which is on the cell surface, on top of the Fc epsilon receptor. Then what happened then? Resulting in an aggregation of the receptor and causing some reaction inside the cell, and there will be preformed mediator release, specifically the histamine. So in this picture, you again can see how this happened inside our body. So from here, so from here, the antigen will enters into the tissue. So antigen will be taken by the antigen presenting cell. Now this antigen presenting cell will bring the antigen to the T cell. In the lymph node, they will present it to the T cell. Which T cell? Which is naive T cell. How the antigen will be presented? By MHC class 2. So they presented the antigen, and there will be T cell receptor. But at the same time, there should be some CD molecules, CD40, CD28, like that, so on. They are the co-stimulatory ligand. So this is very important for the signal 2. So signal 1 means antigen presenting. Signal 2 means there will be the connection between the CD T cell and the antigen presenting cell. And finally, there will be the release of mediators, release of cytokines. So that is signal 3. And we can see how this T cell becomes differentiated to Th2 cell and producing cytokines like IL-4, IL-5, IL-13. And also, this is very important, this specific Th2 cell, a specific T cell will recognize the B cell, that specific B cell. And there will be the class switching. Again, which B cell? That particular B cell who can recognize particularly those antigen. And ultimately, as there will be class switching, so there will be formation of the IgE, from B cell to plasma cell, and there will be formation of the IgE. Now that IgE will come again in the tissue level, and from lymph node to tissue level. And in tissue level, we know there will be the muscles, basophils will be there. They will sit on the top of the muscle. And which portion of the muscle? The Fc epsilon receptor portion. So they will wait for re-entry of another allergen. When there will be a re-entry of another allergen, those Ig molecule which are sitting on the top of the muscle, they will take those allergen, and as they are coupling with the allergen, there will be in some reaction inside the muscle. That particular chemical reaction causes the degranulation, and therefore there will be release of histamine and other mediators. So this is a very important basic thing behind the skin test. As we can see, the wheal and flare response on the skin. This is the positive control, histamine. This is the negative control with distilled water or saline. And this is the ragweed pollen response. So these all suggest the sensitization status with ragweed pollen. So as they are releasing histamine by muscle activation, so there will be a wheal and flare response by increased vascular permeability, leading to localized swelling. So because with skin prick test, we are introducing, this is not the place where we should not do skin prick test. Why, I will tell you later, but it is very important to note. So subcutaneous antigen, if we are injecting it in a low dose, so there will be re-entry of those antigen or allergen in the tissue level, and there the mast cell is waiting. On top of that, the IgE is waiting to catch those allergen. And therefore, after catching those allergen, if that specific IgE is there, so they will catch those allergen, and ultimately there will be reactions, the release of histamine, and ultimately there will be wheal and flare response. So this is the basic mechanism. So the wheal is caused by fluid leaking from blood vessels following muscle activation, and the flare is caused by the local vasodilation and increased blood flow. Again, a few important considerations that we all know, we should know. Skin reactivity decline with age, especially after 60 years. So this, if we have some elderly patient, we may not prescribe the skin prick test. The minimum 2 centimeter distance between test sites. So if we are putting consecutive allergen, between 2 consecutive allergen, the distance should be at least 2 centimeter. Why? Because if it is less than 2 centimeter, that will cause non-specific enhancement by axon reflex. So there will be false positive results. And this is again very important to note. The mid and upper back, 33% more reactive than the lower back. Back is 53% more reactive than arm. And antecubital region is the most reactive in upper arm. Wrist is 50% less reactive than upper arm. That is why I had mentioned previously, we should not do skin test here. And also the ulnar side, 50% more reactive than the radial side. So ulnar side is preferable. So these are few issues we should remember while doing the skin prick test. Another important issue, as we are using positive and negative control, why it is important? Sometimes if it is not more than 3 millimeter, it could be possible that I am taking some antihistamine that reduce the response of positive control, that means histamine. So when we are using antihistamines, it is important to note we should wait for at least 5 half-life to wash out those antihistamine from our system. Otherwise, the skin prick test report may show false negative result. So this is very important, because if we have antihistamine in our body, in our physiology, so that will reduce the histamine response. Tricyclic antidepressant, they have an inherent antihistaminic property, so we should avoid. Now there are some controversies with long-term systemic steroids. This is the Indian guideline which was published in 2017-2018 by Patel Chest Institute, Vallabhbhai Patel Chest Institute at Delhi, which is a pioneer institution where the allergy treatment was provided from very long time. They have a well-distinguished researchers. So this is the Indian guideline, but some foreign guideline, the US guideline or European guideline, they recommend there is no need to actually omit systemic steroids, because in skin prick test, we are assessing the histamine response. But the systemic steroids, they have more effect on the late phase reaction of type 1 hypersensitivity. So they generally not modify the primary histamine response. But if we follow this guideline of Indian guideline, we should wait for at least 5 half-life of systemic corticosteroids too. But for long-term topical steroids, again, this is very important. Both in Indian and now European or US guideline, they are recommending to stop long-term topical. If the patient are on long-term topical steroids, we should stop that before performing skin prick test for at least 2 to 3 weeks. And if a patient already on omalizumab, the anti-Ig monoclonal antibody, we should wait for 2 to 3 weeks. So skin prick test, this is the gold standard for the diagnosis of respiratory allergy. There is no doubt in that. In vitro test, serum Ig is both less sensitive and less specific compared to skin prick test for the diagnosis of respiratory allergy. Here again, we must acknowledge, when we are assessing serum specific Ig, that means they are the free Ig level in our vascular system. Whereas we are assessing skin prick test and getting the response to specific allergen, then we are actually measuring the bound Ig, the muscle bound Ig, quantitatively and qualitatively. So in collaboration with clinical history, most accurate diagnostic test for the diagnosis of respiratory allergy, skin prick test. So again and again, we need to take history first. Then according to the history, we should perform the skin prick test. And after performing the skin prick test, we should again reassess the history, retake the history to have the decision on final therapeutics strategy. Intradermal test has higher sensitivity, but its diagnostic accuracy is limited. There is more chance of false positive result, and also compared to skin prick test, the intradermal test, they have more chance to develop anaphylaxis. So again and again, as we had mentioned, when reporting skin prick test, we should avoid the term allergic. We should use the term sensitized. The patient is sensitized to dust mite, cockroach antigen, or some pollen antigen with a good positive and negative control. This should be the report. We should not write the patient is allergic to dust mite, patient is allergic to cockroach antigen or some pollen. So the term allergic should be avoided. We all should use the sensitized term. And I think from the background, from the mechanism of the type 1 hypersensitivity reaction, we all now can appreciate why we are using this sensitized terminology. Few important points: skin prick test and in vitro measurement, they have almost 80% of correlation. Size of reaction in skin prick test with house dust mite and developing asthma in future, they have a strong correlation. From decline in reactivity with allergen immunotherapy, the size of the will decrease with allergen immunotherapy. We all know the allergen immunotherapy is such a thing which can alter this T-cell mediated reaction. And on that point of view, if we want to assess qualitatively and quantitatively the outcome of allergen immunotherapy, this could be used. Again and again, positive test only signify sensitization, not clinical allergy. We should take a second history to confirm clinical allergy. That is most important. Skin prick test is reliable, safe, quick, and very useful tool in the hands of trained specialist. Again, this trained specialist is very important. That is why we need to increase the awareness on skin prick test. We need to do more practicals on skin prick test, because when we are doing this test, skin prick test, certain movement is required, but if that movement becomes little bit deeper, so it will reach the deeper tissue, and from skin prick test it may become intradermal test. So that is why we should be very much cautious, and we should practice more and more. 20% individuals are sensitized but no allergy. So there is a chance that 20% of the individuals are sensitized but no allergy. But as we had already mentioned, sensitization that increase the chance of developing allergy by 10 times. So finally, the conclusion, skin prick test is an immunological test. It detects the sensitization status. We should correlate with history, and also there is an importance of second history taking before deciding the therapeutics, and also the deciding on allergen immunotherapy. The second history is very important, and the presence or absence of muscle bound specific IG we can assess with this skin prick test. So that is the importance of skin prick test. Whereas by doing the serum assay of by ELISA method or any method, we can only assess the free IG value. So this is the difference. So we had started with some history. We are ending with some history, because skin prick test is not a new thing. It is not a very costly thing, because this test is present for so many years. And we should remember the Charles Harrison Blackleg, who had published the results of what is considered by many to be the first skin test in 1873, when he scratched a small area of his own skin, applied grass pollen grains to the abraded area, and noted a large swelling and erythema. So that is why we need to do this test. We need to understand this test, and we need to increase the awareness about this test more and more, because this is a cheap test, and this test can help us immensely in deciding our therapeutic strategy in allergic patients. Thank you. Thank you for your patient hearing.